So I think we'll change gears, and if you don't mind, Maria, now move on to an area where we both work very actively in, which is in relapsed and relapsed refractory disease. And I wondered if you might like to discuss with our audience, our joint work with daratumumab, particularly in the context of the POLLUX study, as a first step.
Yeah, so you know that the POLLUX is a big phase 3 randomized trial in which lenalidomide and dexamethasone, one of the old standard of care for relapsed and refractory myeloma patients, was compared with Lendex plus daratumumab, the CD38 monoclonal antibodies. And approximately 500 relapsed and refractory myeloma patients after one prior line of therapy were included in this study. Daratumumab plus lenalidomide and dexamethasone was given as continuous therapy, and an update of the trial was presented at last ASH meeting, and it will be also presented here in Delhi in the International Myeloma Workshop, and with a median follow-up of approximately 18 months, so we can observe a significant benefit in terms of progression-free survival for Dara plus RD. And I think that at the present time, I would say that it's the best progression-free survival curve we've seen in a phase 3 randomized trial in relapsed and refractory myeloma patients with a very low hazard ratio. Yeah. This is important, but for me it's also very important the overall response rate, and more importantly the complete response rate, because 46% of the patients achieved complete response. And this was something unusual for relapsed and refractory myeloma patients. And even I would say that we are not seeing this complete response rate in the upfront setting with bortezomib-based combination. So the complete response rate clearly translated into a significant benefit in terms of progression-free survival. But the other important message coming from the POLLUX, and I would say also from the CASTOR, in which daratumumab was combined with bortezomib and dexamethasone, is the role of minimal residual disease. Because if we put together POLLUX and CASTOR, so we will have probably almost 1,000 relapsed and refractory myeloma patients in which minimal residual disease has been evaluated. And I think that the main message is that this study consolidated the role of minimal residual disease and as important surrogate marker predicting progression-free survival. And in fact, if you look at the progression-free survival curves for patients achieving minimal residual disease negative, regardless of the treatment, experimental or control arm, so almost 100% of the patients are free of progression. This is the clear message. But when you look at the number of patients who achieved minimal residual disease negative, is much more higher when daratumumab was added to Lendex or bortezomib and dexamethasone. So I think that we have to try to achieve this minimal residual disease negative status for all of our patients, not only in the upfront, also in the relapse setting. And of course, if we add, in this case, daratumumab to backbone regimes, a higher number of patients are going to reach this objective.
I completely agree with you. I think the MRD data are particularly striking, aren't they? And I think you're absolutely right that certainly in the relapsed refractory setting, to see MRD negativity correlating with disease control for prolonged periods is very, very exciting. It is interesting to me in the MRD world, though, that, for example, in the upfront setting with follow-up, you lose disease control over time. And we see up to 20% of MRD negative patients in the upfront setting, for example, relapsing after 3 years or so. So I think we need further follow-up with our current work to understand that. But I completely agree with you. The results of daratumumab combination therapy are unprecedented. And I think the hazard ratios are the best we've ever seen. And these are yet to combine the two drugs classes, the IMID proteasome inhibitor plus monoclonal antibody platform, which I think is so exciting. And I think in that context, up front now, we're looking at combinations like lenalidomide, bortezomib, and dexamethasone with daratumumab up front. We already have the Maya data, which I know you're involved with, which is RD plus minus Dara up front. So I think there's a whole wealth of information that's going to come through that's going to be very, very promising, I believe, and very exciting in terms of daratumumab use. However, in the relapsed refractory setting, I think we do recognize that Dara can fail. And what I'm very impressed by is that actually new combinations, be it with pomalidomide and Dara, have been studied, and I'd love your thoughts on that. And then I can perhaps talk about some of our other work with other antibodies in the same space.
Yes, of course, because so I think that after bortezomib and after lenalidomide, so pomalidomide and dexamethasone is or was one of the standard of care based on the Nimbus trial. However, I think that in the future, pomalidomide and dexamethasone will be again a backbone to which other novel agents are going to be added. And so I would like to ask you by the new agents that we can add to pomalidomide and dexamethasone, and specifically for the monoclonal antibodies targeting CD38, that I think that you can discuss the role of DARA and also the role of other CD38 monoclonal antibodies in this setting.
Yeah, absolutely, Mavi. So my take on it, I think we're both very much on the same page, is that DARA plus POM, the results are very promising. I think obviously then there'll be the opportunity to integrate a proteasome inhibitor into that platform, and carfilzomib, for example, comes to mind, as does ixazomib. So in that context, the tolerability profiles will matter, because I think we have to recognize that daratumumab, by targeting CD38, obviously has effects on blood counts which are relevant, fatigue. I think very interestingly also there's this endothelial targeting that may occur, that may be relevant to certain proteasome inhibitor drugs that we use, particularly carfilzomib. Now, with that in mind, I'm impressed that the pomalidomide data are as encouraging as we see with lenalidomide. I think the flip of that in terms of other CD38 targeting agents in the same space, we've been very pleased with the performance of isatuximab, so-called SAR, with a long number that I can never remember, but isatuximab is obviously its generic name. Now, this targets CD38 in exactly the same way as obviously daratumumab does, but there are important differences between the antibodies. And I think one of the most important practically is the infusion time. And what we've been very pleased with daratumumab on the one hand being long for the first and then shorter for subsequent, is that with isatuximab, it's relatively short to start with at around 4 hours, and then you cut down to around 2. And what's really interesting also is you can give it every 2 weeks. So from a patient perspective, there's enormous convenience to that approach. What's also exciting to me is there doesn't seem to be a huge difference in their activities. Interestingly, there is some preclinical evidence that isatuximab may have more ectoenzymic or proapoptotic function than, for example, other monoclonals in the same space. Having said all of that, they seem very comparable, and at 10 milligrams per kilo, which is obviously not dissimilar from the 16 milligrams per kilo that we use for DARA, we're seeing promising activity with pomalidomide as a backbone. And that's actually forming the platform for a phase 3 trial combining POMDEX versus POMDEX isatuximab. In our work that we're going to present here at the International Myeloma Workshop as an oral session later today, we will show basically very encouraging results overall. Around 2/3 of patients responding. They are heavily pretreated. Median number of prior lines is essentially 5. And what we are struck by is that it is manageable in terms of its side effect profile. One thing is clear, is myelosuppression. Yeah. And I think that applies to DARA too. But again, it's manageable.
Yeah, because the frequency of grade 3/4 neutropenia is higher than the control arm, higher than we expect with pomalidomide and dexamethasone alone, but you are right, because this is not translating to a significantly higher frequency of severe infections or other complications.
Yes, I think we have to be a bit careful about that, because I think in the context of the relapsed refractory patients I've treated on the study, I'm very proactive with their infectious management. I think you're absolutely right, it's not unmanageable, but I would speculate that it might be higher, because in the more advanced patients, they're more vulnerable. Given all of that, though, thank goodness we're seeing responses in patients who are, frankly, extremely refractory. I mean, these are median 5s, and certainly speaking to my own patients in the trial, several have been in a situation where if this combination had failed them, they would be in hospice. And to see them actually doing well, despite all the side effect management challenges, which are manageable, is really gratifying.
And do you use any specific antibiotic prophylaxis? Or?
Great question. Obviously, we use acyclovir to prevent reactivation of herpes zoster, because that's real with all the CD38s. We are just proactive. In other words, at the first sniffle, at the first cough, particularly with the upper respiratory tract symptomatology, we dive in with antibiotics. And we have a very low threshold for evaluating people in the emergency room or in the clinic if they report any symptomatic issues that may suggest infection. But again, it's manageable. We have certainly not had in our centre any treatment-related mortality from the combination, which I think is obviously an important feature. I think in terms of some closing comments, we're very pleased with the excitement around monoclonal antibodies, aren't we? And I think it's been an absolute pleasure in the daratumumab space to be seeing how that's going, and at the same time to see next generation or arguably just subtly different antibodies come into the same space that could enhance therapeutic benefit.
Yes, of course, we will have a lot of new monoclonal antibodies, because at the end, if we use the CD38 monoclonal antibodies at the beginning, so probably in the upfront setting or in first relapse, so are we going to challenge our patients with the same monoclonal antibodies? Probably we will use another different monoclonal antibodies targeting another antigens present on the surface of the plasma cells, or probably the bone marrow microenvironment.
That's an excellent point to close on. I think in terms of where we are with the antibodies, we not only have exciting ones in the same class, but we have ones that are completely different. And I'm certainly speaking from my own practical experience, we've been able to use elotuzumab-based combinations after daratumumab failure and see responses, although it's obviously not just the antibodies, the other drugs as well. But I think you're absolutely right, Marie-V. The new targets like BCMA are going to be very, very attractive for different classes of antibody. So I think at that point, we will probably close up as to say thank you very much to our audience for listening in on our discussion today, and we hope very much that what we've discussed has been helpful and informative.